Hopefully you can see my screen. All right. Now, Alexander, let's start.
Okay, so 45-year-old man seeks evaluation for weakness, fatigue, decreased libido, loss of body weight. Lab tests reveal low plasma level of ACTH and TSH, both of them are pituitary hormones.
Mhm.
So what is the most likely diagnosis? Probably hypopituitarism,
Mhm.
seeing as both of them are from the pituitary gland.
Okay.
Um, and most appropriately, well, uh, I'm not sure. Probably the actual hormones that they influence, so adrenal and thyroid hormones, what their levels are at.
Okay, let's see. You figured out very nicely that this possible is the pituitary problem. And because the ACTH and TSH already decreased, this could mean that we do have a panhypopituitarism because the most sensitive hormone in the pituitary, the growth hormone LH, FSH, and after the ACTH, TSH, and prolactin is the next one. So possibly we do have a panhypopituitarism. Now you have to think about what could cause this panhypopituitarism because not only one hormone is affected, but a bunch of hormones are affected. Now, what is the first one that you can do? Okay, first of all, immediately you can do the MRI test for sure, because you want to see there's a mass, for example, or any kind of infarction or maybe necrosis that diminish the pituitary. Another thing that we can perform in case, especially when we do have a hypofunctioning organ, some kind of stimulatory test. Now, such as TRH is a very good tool because TRH can increase the TSH and the prolactin. Okay, this is one thing. Another thing that can use, for example, the hypoglycemia by giving insulin to patient because that will increase the growth hormone and ACTH. But ACTH can be stimulated by the CRH test as well, corticoid releasing hormone test. This can apply. Now, if we do have, however, this can happen that we do have a prolactinoma. However, if we do have a prolactinoma, not only the decreased libido and not only the decreased weight, but galactorrhea can be seen in this patient as well, or gynecomastia can be seen. Because if you look at the gland, if you that's sitting in the bunny socket, if you do have a tumor that rise from one type of cells, that level of the hormone will increase. However, because it's going to suppress or compress the other cells, they will decrease. So, for example, if we do have an acromegaly, for sure, we do have an increased growth hormone level. It can happen then together with the lactate, for example, the prolactin level increases. But at the same time, ACTH, TSH, and other hormone level will decrease due to the mass of this enlargement. Could you follow me?
Yeah.
Okay, so
I
that's
do
it.
have a question though.
Yes.
Wouldn't be also should we also measure the actual hormone level at the end, because maybe there's something with the feedback mechanism as well, like in case of ACTH, maybe here the patient is like consuming glucocorticoids or something.
Okay, yes, it can happen. That can happen that first of all, if you do have a weakness, fatigue, decreased libido, loss of body weight, but loss of body weight relatively, if you do have a Cushing syndrome, for example, that can decrease a peripheral Cushing syndrome, that can decrease the ACTH, but that can accompany it with a weight gain. Or if you do have an increase, for example, thyroid hormone level, that can suppress the TSH, however, is not going to alter the ACTH level. You can measure the peripheral hormone levels as well at the same time. You are right, completely right. But it looks like this question is directly asking about the pituitary. But in a true life, this is not the first action that they are taking. First, they are measuring the peripheral hormone level. So first they're measuring, for example, maybe the cortisol level, the thyroid hormone level, and the TSH is asking together, or for example, the progesterone level, but LH-FSH is measured as well. So yes, usually we're starting from a periphery, the target gland, and after go above. But if you do have a typical sign, but mostly what the problem with endocrine diseases, we don't have a straightforward clinical sign. Usually, almost every endocrine disorder can include the weakness, fatigue, decreased libido. So this almost included in every situation. Okay, but
Okay.
don't forget the MRI, for example, or CTs, because that's the imaging techniques are important. Okay. All right.
Okay.
Next
Thanks.
question. Next question. That Biniam.
Yes. And a 29-year-old woman complaining of amenorrhea,
Mhm.
plasma prolactin is elevated in association with low FSH and LH levels. Estrogen excretion is decreased. GnRH stimulation test was performed on 3 consecutive days. The first 2 tests were negative, but after the third test, a normal response was detected in plasma, FSH, and LH. How do you interpret the result of the test, and what is the most likely diagnosis? So let's
Mm.
just address everything one at a time. So
Mhm.
the amenorrhea can be primary or it can be secondary. So meaning primary that she had it. I mean, she's had it ever since puberty, or secondary due to disruption of menstrual cycle, pregnancy, thyroid disease, and prolactinomas.
Mhm.
So the increased prolactin will inhibit
Mhm.
GnRH,
Very
and
good.
this will in turn decrease the FSH and LH levels, which
Mhm.
explains the decreased estrogen levels. Not only that, but they said that the first two negative the tests for detection of normal response, so the stimulation tests were negative, and this can be explained by way explained in the low GnRH levels, which can cause downregulation of these GnRH receptors on gonadotropic cells and the pituitary. So you require more stimulation to raise the FSH and LH levels.
Okay.
Um,
Okay.
Another thing I would consider here is obviously testing, because I would obviously assume prolactinoma because of the prolactin levels,
Mhm. Mhm.
but you have to do MRI to
Mhm.
check if there is a adenoma or detectable adenoma. Not only that, you can check for visual field testing or check for bitemporal like
Mhm.
the
Visual
vision.
disturbance. Yes. Okay.
Exactly. Especially in when you have large adenomas, you have associated local mass effect. Um,
Okay.
I would assume it's prolactinoma,
That's
but
great. That's great. That's good. That's great. That's great. That's great. That's great.
mm,
Whatever you said is completely good. So one GnRH stimulation is not enough. First of all, it should be upregulate the receptors. Plus, normally when the puberty comes, the GnRH secretion that's be positive. So this pulsation should be mimicked as well. If you use a high dose, only one steady state dose of the GnRH, that LHFS is suppressed.
yeah.
So you need some kind of fluctuation of the GnRH. So this should be mimicked as well. And this is due to the prolactinoma what we have here. Very good. Very good. But you should not forget, for example, if somebody has only an elevated prolactin level, that you should ask whether they are taking anticoncipient or anticoncipient pill or not, because that can elevate the prolactin level. Okay,
Okay.
good. Very good. Okay, Buyang?
Yes.
Mm-hmm. Yes.
So a 44-year-old
Mm-hmm.
man complains of impotence and galactorrhea. And these are the typical symptoms of prolactin. It's for men.
Mm-hmm.
And he has, which is abnormal because it's more for prolactin. So we can see that the prolactin has increased for the physical symptoms
Uh-huh.
because it's abnormal, although it's physiological for pregnant woman.
Yeah, but this is not a
And going
pregnant
to,
guy, so it's
yes,
okay.
yes. So moving on to the hematological measurements, we can see that. So we see here the evidence that the plasma prolactin is very high.
Uh-huh.
But on the contrast, we see that the FSH and LH are lower than normal. So it should be
Okay.
the posterior pituitary, and plasma testosterone and urinary 17 ketosteroid
Do you know what the
excretions are,
ketosteroids are?
yes, ketosteroids. They are the overall measurements of the sexual androgens.
Hmm.
So they are the
Metabolite.
metabolites. Yes,
Metabolite. Okay, very
yes.
good.
So
They are not measuring today, so it's okay. It was a cheap measurement, but today is not needed to measure. So it's much easier to measure the testosterone or progesterone and other hormone, because the test that you can get that applied for a machine, the automated counter, they they don't have this. So this is why they are using the hormone measurement. Okay, now let's see what they found after
okay.
TRH. Hmm.
So we have seen that the sexual hormones have decreased and prolactin has increased so far. And after TRH or chlorpromazine
Uh-huh.
stimulation, there is only a minimal increase in plasma prolactin. Um, so for the so with the TRH, we can have the TSH and prolactin releasing factor, and with chlorpromazine, it also increases the prolactin, but then we see that there's only a minimal increase, so
Okay.
that we can see a dysfunction in the prolactin producing cells.
Okay.
But we can see that there are cells intact working, but there's a dysfunction.
Okay. So it's meaning that these cells are active. This highly produces, let's say, the prolactin. This is what you can see. Okay.
Yes,
Chlorpromazine that's a dopamine antagonist.
right,
So this is how the prolactin can be increased. The
right.
TRH has a side effect that can primarize the prolactin. Okay. Very good.
Because
And what
mhm.
test would you perform?
I would definitely perform imaging methods such
Hmm.
as CT or MRI, because
Okay.
this is similar to the case before, except that number two was woman, but in this case it's a man. But I think they are both having the same prolactinoma. So
Hmm.
in order to confirm this tumor, I would do the imaging techniques, and also same treatment I would guess, bromocriptine.
Okay, so dopamine agonist, this is what they are
Yes,
using, and that's
yes.
the best one to
Hmm.
treat the patient. Usually the tumor is going to regress and the patient won't have any problem if the patient tolerates the dopamine, because some patient cannot, and this causes some kind of uh, sign for the patient,
Hmm.
Parkinson sign to the patient, and that's not good. Okay,
Okay.
let's see. 51, that means the Chen Yu.
Hi.
Hi.
Okay.
Okay.
So,
So,
a 50-year-old man seeks evaluation for blurred vision and a headache. He has a coarse facial features and enlarged extremities.
uh-huh.
Determination of which hormone would be the most straightforward in the patient.
Uh-huh. Yes.
Um, Facial
I'm sorry.
features.
Could you stop for a while because I had a phone call. I'm answering and I'll be back right away. Okay.
All right.
Meanwhile, I'm going to pause. Okay. The recording. Okay. So enlarged extremities. This was the last.
So, enlarged extremities indicates some acromegaly
Uh-huh.
of this patient, and maybe the blurred vision and headache might be the pituitary
Mm-hmm.
enlargement of disease,
Mm-hmm.
perhaps a tumor of
Mm-hmm.
some sort. So the question asked me determination of which hormone. Um, it's not the growth hormone,
Why not?
because it's pulsatile secretion. It has
Growth
pulsatile
hormone, yes,
secretion.
but if you do have a tumor, this pulsation is stopped. You do
Mhm.
have a continuous enlargement or continuous elevation of the hormone measure level.
Okay. Um,
But you can measure the growth hormone, yes. But if you want to measure another hormone, which should be the best one to choose beside of the growth hormone?
should be insulin like growth factor.
IGF-1, yes, insulin growth factor 1, exactly. But if you want to see whether that's a tumor adenoma, you should measure the
Either.
glucose suppression test. That
Oh,
meaning
okay.
you give glucose to the patient and measuring the growth hormone level. But don't forget about the MRI because that can be a micro or macroadenoma of this patient, what it has. Okay,
Okay.
good. Let's see the fifth one, Patrick. Patrick.
In a 35-year-old woman, after the third delivery, lactation fails to start. She complains of loss of body weight and amenorrhea. Low voltage is found in her EKG. Plasma levels of anterior pituitary hormones are very low. T4 and T3 are low. After TRH stimulation test, neither TSH or PL increase. Her serum cholesterol level is 8.6 millimole per liter.
Mm-hmm.
Is the problem primary, secondary, or tertiary?
Mm-hmm.
Mm.
Now, what do you think?
So, looking at the symptoms, failure of lactation, amenorrhea, weight loss, I would say that the prolactin secreting cells have failed, and
Yes. Not,
the
not only the prolactin secreting cells are failed,
low
but what
levels of T3 and T4. So, failure of TSH secreting cells. So
Okay.
thyroid stimulating hormone secreting cells are low.
So we
Have
do
failed.
have a pituitary problem. Okay.
Yes.
And that should be the secondary, okay, problem.
Mhm.
Do you know the name of this disease?
Sheehan syndrome.
That's a Sheehan syndrome. That's a postpartum pituitary necrosis that
Necrosis.
can happen. And this way, the first sign could be the lactation doesn't start.
Mhm.
And after you do have a panhypopituitarism, and what you have to do, you have to substitute with the hormones. Usually the target hormone is given. So except GnRH, because GnRH can be ingested and can be used subcutaneously, for example. But thyroxine can be taken orally and cortisol orally. So those hormones can take and can substitute orally. Okay, thank you very much.
You're welcome.
Okay, Fadl.
Yes. Okay, so a 37-year-old man complains of intense thirst. Commenced for 7 days. He drinks 5 to 6 liters of water a day. Urine output is 6 liters per 24 hours, and the density is 1.004. So I would start to suspect from the intense thirst, the large intake of water, and the large urine output that it is diabetes insipidus
Mm-hmm.
due to possibly an ADH insensitivity.
Mm-hmm.
Because we can see that the urine output is also 6 liters per 24 hours. I know normal urine output's typically 800 milliliters to 2 liters in 24 hours.
Mm-hmm.
We can also see the density is 1.004. He was subjected to a water deprivation test with duration of 8 hours. During the test period, he voids 4 liters of urine, and the density does not exceed 1.005. So this tells me that the urine failed to concentrate during the test.
Okay,
And
so this the
yeah,
diagnosis is possible. That's a diabetes
diabetes
insipidus.
insipidus,
Now,
yes.
what for the test you use?
Oh, to test, well, I can determine if, oh, so I did a water deprivation test.
Yes, you already did. This is how
Oh,
you know that
okay.
that's a
So,
diabetes insipidus. But you don't know whether that's a peripheral one, nephrogenous,
oh,
or
yes. So I would carry out nasal desmopressin.
desmopressin test. So orally, you are going to give that vasopressin ADH to patient, and you are checking the density and the volume of the urine. The desmopressin works, meaning that the patient does have a central type. If not, that's a
Peripheral.
nephrogenic type. Okay, this is
Yeah.
how you do it. Okay, very good.
Thank you.
Okay, Istvan.
Yes, hello.
Yeah, hi.
Okay, this is a weird one. A 50-year-old woman complains of polyuria, so similar to the last case. She drinks 6 to 8 liters of water a day, so intense thirst. Serum sodium is 138 millimoles per liter, which is within normal range, though a bit low.
Normal.
Urine output is the 8 liters per
Mhm.
day, which is very high. Density is 1.004, which is high but in normal range. Now, after salt loading, urine volume decreases and the density increases. What is the most likely diagnosis? That last sentence essentially says that the ADH levels or ADH is working within the body.
Okay.
Which is strange because, well, this is a
Okay.
salt loading test.
Okay.
Since salt loading helped, it's probably not diabetes insipidus.
Okay. Yes, because it's working perfectly, so it will do whatever it needs to do. Okay.
Yeah. So she has this intense thirst, but ADH is fine. I don't really know.
No, this is a psychogenic polydipsia. When that's a
okay.
psychiatric disorder, is when the patient drinks a lot, and of course the kidney works perfectly, so they're removing the excess of the water. That's it.
Right.
Okay, so that's a psychogenic polydipsia. This is the opposite of the diabetes insipidus, because in diabetes insipidus, basically, salt loading or water deprivation doesn't do anything. However, in psychogenic one, yes, it does. Now, usually the patient who is not collaborating very well with the doctor, this is why, because they're cheating. If you say that, okay, don't drink water for 8 hours, this patient won't do it because it will cheat and drink water. So this way is very difficult to see whether the patient truly can produce ADH or not. But the salt loading, the Robertson test, that can see immediately, because you increases the osmolality of the plasma, ADH immediately is going to turn on, and water, let's say, resorption is happening immediately from the kidney because the ADH works in the kidney. Okay.
Okay. All right. Thank
Good.
you.
All right. Next one. Okay. The next one.